Okay, so here's a warning. First of all, CLL is a complex disease, and I'm not saying that from any reason other than to protect myself, because it really very much reflects changes in hematological malignancies, and is an exemplar. It's a prime example of something that provides a window into understanding malignancy generally. So yes, this is fascinating. It's a really interesting disease. There's some lovely science, and there are some glorious pictures that look very arty. So yes, let's have a look at those. But remember that CLL, as you know better than I do, has a profound impact on people's lives. And data is only data, numbers are only numbers, and statistics only sometimes apply to the individual. But it's worth learning the lingo. It's very important to have the lingo. It means that we can share ideas and hopefully build a common framework for understanding things at a deeper level, so that when we're talking over things in the clinic, that you know and I know that we're at the same level, if you like. And I think learning at that level is well worthwhile, but it's also important to remember that when we're talking about complex cytogenetics, or doing next generation sequencing, or drugs that only have acronyms and no names, that we don't suddenly propel ourselves from a position of early stage, watch and wait, where there is no need for panic and alarm, up to a position of what the Americans might call DEFCON 5, where we're ready for all-out war. There's no need for that, but we do need to understand what we're talking about. So I think it's finding that balance at an individual level, which isn't always easy. So sometimes the good supportive care, looking after infections, immunoglobulin replacement, for example, antibiotics where they're necessary, sorting out autoimmune hemolysis, all those things that can come along, and all the comorbidities that come with age. And those may matter more than novel agents, for example, or clinical trials, for example. And some of this molecular medicine that we talk about, that I'm going to showcase what I saw at IWCLL, at least some of it, but much of this is not in routine practice yet. So let's bear that in mind, and then hopefully just move on. So we're going to talk about the basics. Now, the basics have changed, and a few years ago, the basics weren't the basics. We were all struggling to come to grips with immunoglobulin heavy chain gene mutation analysis, and ZAP70, or the importance of P53. Now, we can't dwell on that. We've got to move on. So the basics have become those things. So we're going to talk about the basics of genetics and immunoglobulin gene mutations, because immunoglobulin genes are at the heart of a CLL cell. This is a B cell. And B cells patrol around the body, making antibodies to fight infection. It's what they do. And at the heart of that cell is the machinery to make those antibodies. And CLL cells are just the same. They have that machinery there to a more or less extent. So some CLL cells are more normal and have the capability or the potential in their genetic makeup for making a more normal-looking immunoglobulin, and we call that mutated. And some are less normal, less mature, and the genetic makeup and the machinery to make those immunoglobulin genes is less sophisticated, and we call those unmutated VH genes. The CLL cell is not alone. It lives in a milieu, bunch of cells around it that it communicates with. And at the heart of one of the problems in CLL is the B-cell receptor. And the biology around the B-cell receptor is something that's becoming better understood. And of course, it is currently a very strong therapeutic target. So I hope that you're going to be able to forgive me for sort of moving beyond some of the basic things fairly swiftly, but I thought that it would be worthwhile just going through that fairly rapidly. So international prognostic indexes, this is going to be something that is a collection of clinical and biological variables that all go into the mix. So you can add up the scores, if you like, and say, well, if you've got more of these problems than overall survival, I'm going to talk about some difficult things today, but overall survival is going to be less. But let's not forget that much of this is based on historical data that doesn't necessarily reflect current treatment. And therefore, a lot of these lines that you see that appear to be heading inexorably downwards don't necessarily reflect the current clinical situation. Okay? This goes back 17 years now. This is Hartman Donor's data on fish cytogenetics showing the importance of 17p deletion. That hasn't really changed. It's still an important problem that we're coming to grips with. And we know that it's not all done by fish these days. We do mutational analysis to see whether the p53 gene is normal or not. We know that for most people who have the deletion of the 17p chromosome, they also have mutation of the 17p gene, but some of them just have the mutation, some of them just have the deletion. And the frequency, does this point? Yeah. And the frequency of this as a clinical problem or a genetic problem increases over time with those patients requiring treatment, refractory CLL, and in Richter's syndrome. And I'm going to show some more data on that as well. And then sort of moving forward, slightly lightheartedly, but things like fish don't tell us the whole story. And while they may be very much part of our routine NHS practice at the moment, it doesn't shed sufficient light on the problem. So this is a cartoon strip of the elderly gentleman kneeling down, looking in the gutter. It's obviously been a late night. And the American police officer comes up to him and says, "What are you doing here?" And he says, "I'm looking for my quarter that I dropped." He says, "Did you drop it here?" He says, "No, I dropped it 2 blocks down the road." He said, "Why are you looking here?" "Because the light's better." And what we've got is we've got a patch of light at one bit down the street, and we want to shine light all the way down the road so we can see every bit of it to find the problems. Otherwise, we're going to miss something. And these are clever boxes. They look like black boxes, and I have no idea what's inside them or how they work. So that's one of your questions off. Okay. This was an important paper from David Rossi, an Italian group, from a couple of years back, showing that p53 mutation, if you look hard enough, you can find it at low levels, and that's important. So it retains some of that prognostic value, even when you find it in small numbers of cells. So we're going to start learning some of that lingo and start talking about things like subclones, because the CLLC is not all the same. All the cells are not all the same. Some of them are going to be different in much of their genetic makeup, and they're going to be clones and subclones washing around in varying different proportions. And this is one of the things that we've learned over the last few years, and is something that I think we're all struggling to get to grips with, about the significance of those, how hard do we need to look, what do they entail, etc. But this is what we've got to talk about. Okay? So subclones and exploring the subclonal architecture of CLL. So those are the words. You know, if you struggle with this, you're not alone. We all struggle with this. So if we look hard enough, and it's this bit here, down here that's important. So looking at the bulk of CLL cells and CLL cases, you can find smallish or varying proportions of p53 mutation. But if you use those deep sequencing techniques, like taking one of those Jacques Cousteau submarines right down to the bottom of the ocean and see what's scuttling around on the ocean floor, you get this tail of small subclones of CLL that contain the p53 mutation. So it's there. How hard do we need to look for it? We don't know that. Immunoglobulin gene mutation analysis reflects some of the journey of a normal B cell. So you start off with a naive B cell that has never seen anything in this world, and it's skipping along very innocently, and it's not prepared to make an antibody that is particularly useful for anything until it becomes more experienced immunologically, and it gets exposed to viruses, bacteria, the inner machinery of the immune system, and out it pops at the other end as a memory B cell. These are plasma cells that are cousins of mature B cells, but they go on to form things like plasma cell myeloma, and this is sort of how they're related in some ways. So memory B cells. So somewhere between here and here is our CLL, and again, that's sort of where we're learning to look for. And we know that for those people who have the immunoglobulin gene machinery that is more normal, they do better. We call it mutated. And those people who have less mutated or unmutated VH genes, they don't do so well. And that's all that these graphs show. And this is quite old data now. This is IWCLL. This was 18 years ago. And this is the cell communicating with various of the cells around it. So T cells, macrophages, nurse-like cells, all sorts of vascular cells, cells in the blood vessels. And it's sharing and communicating at a molecular level constantly. It's not just a passenger cell. It's not sitting there idly, a victim of circumstance. The CLL cell is probably pulling these cells in around it and making it happen, if you like, because they really, really want signals coming straight through that B cell receptor. This is how those cells survive. This is Darwinian evolution of the CLL cell, if you like, that it's addicted to those signals coming in through the B cell receptor, and it's manipulating the microenvironment so it gets exactly what it needs. And that's part of what's at the heart of more modern therapies when we're talking about drugs like ibrutinib. And I think that sheds light on the whole process of CLL. So a lot of my talk today is going to be around this whole area. Okay? So just a quick slide to confirm, if you like, that B cell receptor signals are required for cell proliferation. Without it, the cells do not proliferate. So just a collection of data from a number of papers over the last few years. Okay, so that was the basics, right? Moving forward at IWCLL, there were a lot of presentations. You can't recreate the whole of CLL today. So I'm not going to do that, but this is a distillation of some of the slides that I made after going to the meeting. So there were key things and themes that I thought came out at the meeting. A lot of it was related to p53 still. A lot of it was related to subclones and clonal evolution and how CLL changes over time in relation to the microenvironment. And we have a question already.
Can I try and get my head straight?
Yes.
Yeah. Is the CLL the lymphocytes? Is it like the conductor of an orchestra where it's trying to pull in other cells?
I'm not sure I can say that exactly, but I think it is in some way manipulating the environment so that it's doing more than just responding to things around it. I think it's actually sucking things in some way, if that makes sense. I think it's quite an active participant in the process. IGHV genes, it's not just one immunoglobulin gene in the CLL cell. There are families of immunoglobulin genes, and they're all subtly different. And some of them might be in response to different signals that the CLL B cell might once have had. And it expresses those families of immunoglobulin genes in a different way. And some of them are clustered and grouped together. And we call that stereotypy. And then there were novel therapeutic approaches. So we can say, oh gosh, what's on the horizon? What's new? Let's have a look at that. So again, I hope that the tenor of this talk might go down a little bit as we discover all the problems in CLL, but hopefully we'll come back up again towards the end when we're talking about the prospects for therapy in CLL. So, right, epigenetics. Epigenetics are the genetic changes that don't actually code for anything structural or positive. There's no protein at the end of it. It's just genes that are there and genetic material that's there. What does it all mean? Yeah, there was one theory a while back that this was just all noise. Well, it probably isn't noise. And this genetic material does something. It informs the way cells work. It informs the way that that chromosomes might fold, unfold, which genes are expressed, which ones are underexpressed. And there's this process called methylation. There we go. Sticking a carbon and 3 hydrogens, a methyl group, onto one of those carbon rings that forms the backbone of any organic chemistry protein, including amino acids. And this methylation can either be more of it or less of it, and it changes and influences gene expression without itself actually being a protein gene, if you like. And if you look at this graph at the bottom, if you can read it, there's lots of methylation processes going on in the B-cell receptor signaling pathway, B lymphocytes, B-cell receptor, B-cell survival pathways. So methylation pathways, or methylation of genetic material, is clearly involved in some processes, some genetic processes in the CLL cell, in the B cell, that are highly important, highly relevant to how CLL might behave in any one individual. And if you look at this normal, this is a bit like that big blob I showed you with the naive cell going towards the memory cell. It's showing it in a slightly different way. It looks like an evolution chart, starting with an amoeba and ending up with Homo sapiens or something like that. But this is the naive B cell here, and the memory B cell over here. And you can see that there's a trajectory, a pathway down which the CLL cell goes. But if you look at the methylation, it suddenly looks like a hedgehog. And the CLL cells are flying off in all sorts of different directions, not necessarily in a straight line, but with subgroups of those B cells that sort of semi-reflect the normal maturation pathways, what we call recapitulating the normal B cell, after a fashion, but perhaps not quite. And you can divide those up into how programmed they are, how much methylation is going on. So there's highly programmed epigenetic material that's got areas of much less methylation or much more methylation. And there are areas where, well, there's not much difference, there's no real change, it's low programmed. That's the term that gets used. So I'm just learning the lingo too. And you can then map that back to things like immunoglobulin VH mutational status. So what about that active methylation, that highly programmed epigenetic material? That all seems to cluster in the mutated CLL group. Look, there's 100% mutated, 98, 96, 94, 92, 90, 88, less and less and less mutated immunoglobulin gene. So there's a big cluster in that mutated group. the good group. And then if you look at the low programmed methylation, that cluster's big spike at the 100%. This is the unmutated CLL, the poorer group. So you can actually pull this apart and look at mutated and unmutated CLL, and then say, well, how much of that program is going on? And you can subdivide the good bits into even better bits and slightly worse bits. Or you can subdivide the unmutated CLL into those which actually do have a proportion of high programming, and they do seem to do quite well, and those ones that don't have much programming at all. So that's epigenetics. So understanding this, I think, is something that I'm struggling with. I'm communicating that to you down a very narrow or shallow gradient, I think, but nonetheless, these are the terminologies that we must learn. Okay, moving on. Receptors in CLL. These are the fingerprints of the immunoglobulin. You might recognize this sort of Y-shaped thing that we draw as a cartoon of an immunoglobulin, of an antibody. And the business end of it, the bit that gets to grip with a bacterium or virus or whatever it might be, is called the complementarity determining region. And that's where all that mutation occurs when we talk about mutated and unmutated. And these are the family groups that I mentioned. And we often talk about VH321 and other subgroups, other families of VH gene usage, the variable heavy chain families. And we know that some of them appear to do better than others. We call those subsets. So subset 4, subset 2, this is 321. And that's just a nice picture. That's how the sequencing, when it's drawn out, comes out as a nice coloured numbers of amino acids, letters of amino acids. So subset 2, fairly aggressive. It's got lots of B-cell signaling going on, very avid B-cell receptor. Subset 8, 439, appears to be associated with Richter's transformation. So subset 8, 439, higher risk of Richter's transformation. And you can see this graph here in this particular study that there was really a very high incidence of Richter's transformation in that particular group. Okay? So quite discouraging information in terms of transformation. But maybe if you've not got that, perhaps the risks are lower. In terms of immunoglobulin genes and how people respond to treatment, this isn't new news, but this is just data that was shown again. Again, goes back a couple of years now, looking at response to FCR, one of the still very commonly used chemotherapy regimens in first-line fit people who can tolerate FCR. We looked at the mutated group. Those people seem to respond better overall, which is kind of interesting. So if you give our chemo, particularly FCR, then the mutated group seems to do well. And this is a bit of a thorn in our side because we want there to be a level playing field. And if you've got somebody who's got heavily mutated CLL, you're trying to make a choice, particularly in a clinical trial, and you know that maybe this person might do really well with FCR, how much do I want them to be in a study where they're going to be randomized to something else that may not be strictly necessary, but what we think of commonly as nice to have, let's say ibrutinib, if you went in a trial comparing FCR with ibrutinib, but you had heavily mutated CLL, you might do really well. And then suddenly you're randomized to ibrutinib. So, it's balancing that out. And there are no answers to this. Doesn't seem to make a difference to ibrutinib, though. So that's nice to know. Okay, so Dolly the sheep, clones and subclones. Ibrutinib's there at the bottom as well, so let's see what we can come up with. So let's not forget, first of all, that some of the newer agents that we're now using very widely, ibrutinib, idelalesso, venetoclax, increasingly have very high response rates in relapsed refractory CLL. So let's have that as our starting point, because these are all excellent drugs, all of them, all three. We're going to talk about subclones and mutations. And one of the words that you may hear are things like driver mutations and passenger mutations. So imagine that the mutation is there and is something related to the bus driving the CLL down its pathway. If it's a passenger mutation, it's just sitting at the back of the bus looking out the window. It's not doing anything. But a driver mutation is one that's actually navigating the CLL towards where it's going to go. So that's the lingo, driver mutations and passenger mutations. And there's this concept, which is kind of interesting, of reverse engineering, going from lots of cells, the CLL existing as lots of different types of subclones all coexisting very happily, to becoming more mutated and then selecting out some of those cells that are going to survive better. So it goes from this sort of multicellular organism much more to a unicellular organism where those cells are uniquely positioned, where they almost position themselves, going back to that question, they almost position themselves to become more suited to the microenvironment in which they find themselves. They become more adapted to it. They become tougher. A complex karyotype is where there are lots of different genetic problems, and that, because it's out of control with lots of mutations, carries increased risk, and responses are less good in the context of complex karyotype. These are the subclones of p53. I'm going to just talk about this very briefly, and we've seen this slide already. So there's that tail of cells or CLL populations with tiny subpopulations of p53 mutations. Is everyone familiar with p53? More or less. It's one of those cell checkpoint proteins that if you damage the cell, then it allows the cell to die. And if it's not working, the cell can't die. So you can give chemotherapy till you're blue in the face, and the cell might look ugly, but it won't die off unless it's got functional p53. And that's the problem with it. You can damage the cell without killing off the CLL cells. And what's increasingly clear is that you don't need very much of it for it to become a problem. And there are other genetic issues and genetic subpopulations as well that we can pick up. So SF3B3, Notch1, so various things that can come up. So Notch1, again, though if you have the mutation in a Notch1 gene, then it seems that overall survival is reduced, and from time from diagnosis to treatment is reduced. And if you have a Notch1 mutation, then adding rituximab doesn't seem to make much difference. That seems to be the information we're getting that's coming out of one of the two of the German study group papers, when they eventually go back and do the analysis on the cells that they've collected over the years. So small subclones, when you're treating people, if those cells are resistant to the treatment, what happens to them? They increase in size. They get bigger. I know this is a very busy slide, but I'm going to show the data in several different ways that I think will make it much clearer. So essentially, if you're harboring a small subclone of p53 cells, they may well be selected and will grow over time. So that's another way of showing it graphically. That you start off with a whole bunch of cells everything goes down, but as a proportion, the resistant cells will grow and become a higher proportion of the CLL in due course. Just like this. There might be one cell, whatever percentage, small percentage of a p53 mutated cell lurking in the CLLC. And you give treatment and everything gets smaller, but what disappears? The healthier cells, the more normal cells, the less well-adapted cells. And then what grows back is this more complex population with the mutation in it, and maybe other mutations as well. And it's fairly clear that in this study, 330 people measuring p53 subclones, that if you leave them untreated, or the untreated patients, because they don't need anything, they don't select out those clones. But as soon as you start to treat people, the proportion of p53 cells increases. So it's kind of important, isn't it? And there are lots of different patterns in the way this can happen. It could be a mixed, that some of those clones go up, some go down, or they all go up. So a complex slide, but a very simple message. We don't know what's going to happen in any one individual. Those subclones are going to either go up, down, or sideways. And are we going to measure it? This is research. We're not going to measure it. What about ibrutinib? Who relapses with ibrutinib? Is it all those p53 cells, or what is it? And this has been the subject of, as you can imagine, intense research over the last couple of years. You know, why is it that people eventually, in some cases, grow out of their ibrutinib and relapse? So the yellow line here reflects Richter's transformation, something that seems to occur fairly early on in the course of ibrutinib and then seems to plateau out. There are other events, so it might be infections or something else that happens, some secondary malignancy, some bleeding problem, and people come off ibrutinib and become, you know, unwell. And there are other people who have gradually progressive disease as time goes by, and that gradually accumulates. So why is this happening? What sort of changes are there? And of course, it's genetic. There are mutations that occur, and those mutations are going to occur somewhere in the B-cell receptor or down further on, somewhere in the signaling pathway that blocks the effect of ibrutinib. Maybe there's some kind of upregulation somewhere else, so the cells become more active. Slightly busy slide, so I'm going to move on from this one, but essentially it just picks up within a group of patients that was presented on this paper who have background of complex karyotypes, 17p deletions, had largely been on ibrutinib and had relapsed, and they were found to have different mutations. So mutations in the BTK receptor and mutations in phospholipase gamma 2 are the classic mutations that we are seeing emerge in people with resistant ibrutinib. And we can pick that up early on if you look hard enough for it, and that could be a predictor of relapse and resistance to ibrutinib. Again, are we doing that? No, we're not. We're not screening people for resistance of ibrutinib early on, because you want to maintain a clinical response for as long as possible, I would suggest. So in essence, there might be something else that happens, some other lymphoma, some other cancer perhaps that happens, or an early Richter's transformation, and then the development of a mutation in the BTK, or some other additional mutation, and then there's an evolution, the clone becomes increasingly resistant, becomes selected out, and then you have a clinical relapse of the CLL. So those, as a proportion, seem to be the commonest types of mutations in CLL. In Richter's transformation, we're not really seeing that. We're seeing other mutations, so nothing directly associated with the ibrutinib. What happens when you stop? If you stop ibrutinib for some reason, things start to happen, and this is not good news. I'm going to show some data that we presented as part of the UK CLL forum at the Lugano meeting a week or two ago. So essentially, if you stop ibrutinib, then people will die quite quickly of progressive CLL, if that's the reason for it, or Richter's, or infection problems, but you take away the B-cell receptor blockade, and the cell just says, thank you very much, I'll have that signal again. And it avidly upregulates and draws in the signals straight through, back through the B-cell receptor. And you get progressive disease very rapidly. So this is a poster at the ICML meeting reflecting a sort of concerted effort on behalf of the UK and Irish physicians, hematologists, on data from people receiving ibrutinib through the early access program, the compassionate use program. Okay? So there may be people in the room who started off on ibrutinib in the compassionate use access program. Your data will almost certainly be in this. So we've collected almost 100% of everyone in that program and have published it in Hematologica last year and an update at the Lugano meeting this June. So essentially it was, what happens to these people on ibrutinib? 315 people. What happens to them? How many of them have to come off therapy? You know, how many are still on it? And how many are still alive? How many are not? I don't know if you can read this, but most people are still on the ibrutinib. Does it matter if you have 17p deletion or how many courses of prior therapy? No, it doesn't seem to matter. So most people who have got those genetic problems are doing just as well as those without. So ibrutinib is a great drug. It works very well despite what you've got. But the problem comes if you stop or have a break. And there are different reasons why people might have a break from ibrutinib. If you have an infection and your hematologist says, okay, I think we just need to hold off this, maybe there's a bit of neutropenia or whatever it might be, some additional risk of bleeding problem, for example, or you know, clinical now suggesting that a bit of a week or so off ibrutinib might be in your better interest while we sort out whatever it is that's going on. If it's an infection, it's not so bad. If it's something else, then that seems to be more of an issue, more of a problem. And the longer people have as a break from ibrutinib, the worse it's going to be. And that cutoff, we did an analysis. It's statistically, you have to draw a cutoff somewhere. So we said more than 14 days. And if you stop ibrutinib for more than 14 days, the outcome is worse. And a proportion of people will have come off ibrutinib during that first year, and a proportion will have come off in later, after 2 years or more. And of those people who had progressive CLL in the first year, 10 people died. So progressive CLL, in the first year of the early access program, 10 people died. In the second and subsequent year, 15 people came off ibrutinib because of progressive CLL. And of those, 5 died. So a couple of them were on idelalisib, moved to idelalisib. One of those died and one is still alive. 3 of them had palliative care, and one we're not sure what the outcome was. And 9 of them received venetoclax. So the difference between year 1 and subsequent years is venetoclax. And it's made a big difference to anyone who is progressing on CLL, moving forward and accessing this drug. So it's something that as clinicians, and I'm sure as a patient group, we're all very, very keen to access as and when we can if we need it. So we don't really know, was it stopping it or was it the reason for stopping it? Was it because that person was already ill, or was it because stopping the drug was the key thing for having a 2-week break? We don't really know that. But what we do know is that between the early half of this study and subsequent, the difference was access to venetoclax. So venetoclax, this is data presented by Peter Hillman. Very grateful for his slides that he shared with me. He presented at the European Hematology meeting in Madrid in June, a couple of weeks ago. And this is on a study. It's one of the Trials Acceleration Program studies, various centers around the country, and uses ibrutinib with the addition of venetoclax. So a very interesting trial. And does that provide some other way of controlling CLL? So this is emerging data. It's not the whole story. It doesn't tell us exactly how we should treat people, but it gives some additional information. Now, CLL is a mixture of the cells proliferating, growing, and dying off. And there's a bit of a balance. And one of the things that allows those cells to die off is this process known as apoptosis. So the cells fall off, from the Greek to fall off. And one of the proteins that facilitates this cell death mechanism is BCL2. It's a family of proteins. There are lots of different subtypes of BCL2, but one of them is pro-apoptotic and causes apoptosis. And if you give something that looks very like BCL2 into a CLL cell, the cell will be fooled into thinking the BCL2 is upregulated, it's got to die off. So it causes very rapid cell death. It causes apoptosis very, very quickly. Now, historically, it's all started with Ogden Bruton, who was at one of the army hospitals in the US and described children. His first case was an 8-year-old with X-linked agammaglobulinemia and a history of infections, and found that child, that boy, didn't have enough immunoglobulin. Fast forward a few decades, and now we know that it was a mutation of Bruton's, named after him, tyrosine kinase. And that just means an enzyme. A kinase is something that moves something, pushes something, changes something. So Bruton's tyrosine kinase is mutated in that group. So if that causes agammaglobulinemia, and those people have a very much reduced B cell, surely that's a good target. So hence ibrutinib. Does that make sense? Apoptosis through BCL2, what we just talked about, venetoclax, mimics the BCL2 and triggers this process of apoptosis. It has a dramatic effect. And one of our worries with it is that when you give it, if you've got a very high white cell count or bulky lymph nodes, that it can kill all those cells at once. And there's a traffic jam of proteins and gubbins that needs to come out of the body through the kidneys, and we call that tumor lysis syndrome, which can be very dangerous and may necessitate hemodialysis or intensive care, for example. And we pick that up through changes in the salts in the blood, the potassium, changes in renal function, phosphate, uric acid, a number of parameters that we look at and monitor carefully as patients start their venetoclax. So what if we gave both of those drugs together? Is it going to affect that tumor lysis pathway? Is it going to improve some of the outcomes for these people? So this is a small study, and one of the measurements was measuring how low you could get the CLL. So you may be aware that when you give ibrutinib, you don't always get a drop in the lymphocyte count. You get these stunned cells that then wander around the blood, and they disaggregate out of the lymph glands and increase in the blood. So you often have an increase in the lymphocyte count. Doesn't mean the drug's not working. It's just what we see. But with venetoclax, you get a very rapid drop in the lymphocyte count. So we want to know, what about minimal residual disease? Minimal residual disease is a concept of measuring very low levels of disease with sensitive techniques such as MRD flow or other molecular techniques to pick up vanishingly small numbers. And if you get down to very low levels, then that has quite profound implications on duration of response. So the lower the disease, the longer the remission is likely to be. And that's not been something that we've been able to attribute directly with ibrutinib, because it doesn't cause that profound drop in the lymphocyte count, but venetoclax does, so sticking them together. As of last week, it says there are 2 slots left. This data was from EHA in June. 3 weeks later, Clarity has fully recruited, and it recruited very well across the country. So 50 patients. And of those 50 patients, most of them are men, as you might guess, with CLL. They had mostly advanced stage disease. They'd had between 1 and 6 prior therapies. They had largely mutated CLL rather than unmutated. 44% of them had what we might classically consider as being poor prognostic cytogenetics, including 20% with 17p deletion. And the idea was that you'd give 8 weeks of ibrutinib and then start the venetoclax with this escalating dose, which is the way that we give the drug, by mouth over a period of a number of weeks until you get to the steady state dose of 400 milligrams. And then check the blood on a regular basis to see whether or not there is any MRD negativity. And you carry on with the venetoclax for up to 2 years, and if you become MRD negative, then there's an opportunity to stop both the drugs. So we don't have that data yet, but what we have got is some of the data on tumor lysis. There seems to be very little tumor lysis, so the take-home message with combining these drugs together is, firstly, you can do it, and it may actually improve some of the safety profile of using drugs like venetoclax. That needs to be confirmed. And this is just the schematic of a little bit of overlap to begin with, starting the ibrutinib, and then overlapping the drugs, monitoring the blood and the bone marrow with the opportunity to discontinue these treatments if you reach an MRD negative state. So this is in theory at the moment, and hopefully we'll see some of that borne out with data in due course. There's an amendment to the Clarity trial. It will be reopening and extending further. These are the side effects, adverse events, in the Clarity study. Most of them relate to things that we see with ibrutinib rather than things that we might see with a combination of drugs. So it doesn't appear as though that the combination is really very much worse than one or other of the drugs individually. And the vast majority of side effects are what we call grade 1 and 2, which as doctors we think are manageable, but I defer to your judgment on whether these are acceptable or not. There was a single case of Hemolysis Syndrome, and this was somebody who had escalated and was up to the 100 milligram dose and had biochemical tumor lysis rather than needing hemodialysis, and was managed with fluids and resburicase and recovered and just continued on up the escalation pathway, and no further problems. So this is interesting safety data. Adverse events of interest. Neutrophils reduce grade 3 in a number of cases. Bleeding problem, hematoma. Would that have happened with just ibrutinib? I don't know. A vitriol bleed, a bleed at the back of the eye occurred as well. That was thought to be fairly mild. Blood responses, this is early data, so not expecting to see formal MRD and influence on overall survival, etc. But of interest it is that we have got a median lymphocyte count of 50 going down at month 5 down to 0.01. At the lower end, 0.002 to 0.08. So some very low lymphocyte counts, much lower than we would see normally with just ibrutinib. So early data, but clearly profound lymphopenia. A couple of slides to show what happens when you start ibrutinib, and you can see the little jump, little leap. As people start ibrutinib, the lymphocytes go up, but very rapidly fall as soon as the venetoclax starts. Even during the very early phase, when we would not consider, let's say, 20 milligrams or 50 milligrams of venetoclax to be particularly a therapeutic dose. So remarkable that the lymphocyte count drops so quickly. One of my observations, and I believe the observations of my colleagues, is that when we're starting venetoclax at a low dose, that we often get concerned that things are really quite shaky to begin with until the level goes up and the CLL comes back under control again. So that's not an issue that we're seeing here. And this is the same data, but with a different scale. It's a log scale on the side, showing a 1,000-fold decrease, a 3-log decrease in the lymphocyte count. Again, beginning at that very early low dose of venetoclax, almost as soon as it starts. The Flair Trial. This is standard of care now for fit patients in the UK, and we've had a one-to-one randomization between FCR and ibrutinib and rituximab. There is a modification to the Flair study currently that it has a 4-way randomization between FCR, ibrutinib single agent, ibrutinib and rituximab, and ibrutinib and venetoclax on the basis of some of this data coming out of Clarity. So moving away from FCR, moving towards the novel agents as time goes by. So this is the amendment. It says to start June 17. As of last week, there were 40 centres in the UK that were in the process of or had fully sorted out the amendment. There will be an overlap. Officially, it's the end of this month, end of July. It will probably be extended to the end of August for old Flair, if you like, before new Flair takes over. So for those sites in the UK that have not yet been able to move across from old Flair to new Flair, that will close at the end of August. And there will be a 75% chance, if you go into the Flair study, of receiving an ibrutinib-based therapy. I think this conclusion just says, again, that venetoclax is well tolerated with ibrutinib and that there's a rapid reduction even at an early stage. Number of centres around the country that were involved in this data. So all is not lost. And at IWCLL, again, there was a proliferation of data on the new agents, such as ACP196, ONO, GS4059, Beijing 111 drug, all of which are novel BTK inhibitors. And Tom Kipps from California gave us a new one, so another new mechanism for treating CLL. So some interesting data. I'm not sure that it's the answer yet, but it's ROR1 and a ROR1 inhibitor. So this is the human kinome. You know the human genome? This is the human kinome, all right? There are lots of ohms knocking around. So this is a map of all those proteins that push something to do something else. And somewhere up there in the top reaches of the branches is ROR1. And ROR1 signals through this Wnt5a pathway and essentially leads to cell proliferation and cell migration. So the CLL cells have a bit more get up and go, and they proliferate more. And if you've got more of it, then you do worse. So that's a recent data from Tom Kipp's group saying, here we go, ROR1, more of it, bad CLL. So let's have a trial. Drug company comes up with a ROR1 inhibitor, you give the drug, and what happens? You have some reduction in bone marrow cellularity. This is a bone marrow trophine biopsy indicating heavy bone marrow infiltration pre-treatment with what looks like a modest response in the trophine biopsy. It's still got quite a lot of lymphocytes in there, but it's got fat spaces too, so it looks a little bit less packed than it did. And similarly, with the CT scan, in one case showing reduction in a lymph node mass of the retroperitoneal area is significantly improved. So some improvement, sort of slightly better than stable disease response. And again, when you give ibrutinib with this drug, you don't get that increase of the lymphocytes. It gradually goes down again. So you start the ibrutinib, and the lymphocytes disappear. So there may be some synergy. And that's the same data here. You give ibrutinib or ROR1 inhibitor, the lymphocyte count stays basically the same. As soon as you put the two together, boom, down it goes. So interesting synergy. And it doesn't tell us much more than that. It just says, here's a novel mechanism, here's a new drug, here's a new target, all is not lost. So, what do we do next? We need to understand clonal evolution. We need to understand subclones. We need to get a better handle on that and what it means for any one individual. And that's quite an undertaking if you think about the efforts and the resources that might need to go into that. How do we manage ibrutinib resistance? It's a big issue, and that depends on the funding mechanisms in the UK. And how do we manage Richter's transformation? What's all that about? How do we get that under control? So, our understanding of CLL is still expanding very rapidly. And there's this glossary of terms, and I love the idea of having all these acronyms explained. I think it's essential, but we have a lexicon of CLL that we're all getting to grips with. The B-cell receptor is pivotal to the biology of CLL. There are subclones washing around. It isn't just a bland one color, one size fits all. There are different cells within what looks like an otherwise homogeneous group. They're not all the same. There are subsets of the immunoglobulin genes, subsets of usage, different families, and that has an impact on the biological behavior, on the real-life behavior of CLL in any individual. There are things going on in the genes or the genetic material that doesn't code for anything, the epigenetics. And there are mutations in there that may drive it, like TP53, or they may just sit in the background and wait for their turn to influence things. But there's a lot more to say. There's the 100,000 Genomes Project. There's biobanking, and a project to not only include samples from patients within studies and with trials, but in current setup, a UK-wide study to have a biobanking project on people who are outside clinical trials from the time of diagnosis, so that when it comes to pulling it all together, we don't suddenly start at year 30 or 40, we're starting at year 0 or time 0, when we can understand the whole of the evolutionary process. So that's quite an important thing to do, we feel, and that's an NCRI badge study, observational study that is beginning to roll out across the UK. There are other new drugs, of course, and we're learning to manage a new set of complications, and we're managing things that emerge at a later stage that we never saw anyway, maybe consequences of clonal evolution, or maybe other problems that people get because of living longer with CLL, increased frailty with age, that we haven't seen necessarily in the context of CLL with everyone. I'm not sure I can say much more about NICE. We had a general election, everything went into purdah, and things like venetoclax, we won't hear anything different until September. There is the social care, support, psychological problems and social problems that arise and impact everyone's lives with CLL. And that's something which I think is not widely discussed and is not well understood. And it's something that I've discussed with Brian and one or two others about looking into, with the cooperation of the CLL Support Association, some of the social impacts of CLL. Now, I don't know whether that's going to take off or not. It all depends on funding, but it's something that I'd be interested to take further. And I think that's it. Thank you very much.
Ben, thank you for, what I thought was an absolutely fascinating sort of insight into the complex inner workings of CLL, and also encouraging news about, as it were, the growing toolkit of therapeutic kind of options available. There's still obviously, a way to go, but it was really fascinating, and thank you very much. Now, there is an opportunity to ask questions of Ben, and Ben will endeavour to respond as best he can to those questions.
Sure will.
I don't know whether anybody's written any questions down. We've got a few written questions, so I'll perhaps ask one of my colleagues to collect in the written questions. And meanwhile, we've got some sort of roving mics here, which, again, I think trustee colleagues may take around. And so if you could perhaps put your hand up if you have an immediate question that you'd like to ask Ben, and Jeanette, I think, will come over with the mic.
It's a good sign that there are some questions, because if I really confused an audience, people wouldn't know what questions to ask. So I'm delighted.
I can probably talk loud enough, actually.
Okay.
Most people would say I do. For those people who are in a Flair study,
Yeah.
and I'm on Rituximab, the original Flair, then the plan is for the Apoptosis to start to say there's no evidence of disease after so many years. Yes.
Yes, that's correct.
That makes us feel quite anxious, actually. I wanted to ask you, the question is, how do you see those patients being salvaged once they progress? Do you think they'll re-mitigate on ibrutinib, or do you think they should have venetoclax, which may or may not be available to them, because they may not fall into the right group for nice treatment?
I think it reflects, a huge sense of uncertainty when you get as far as drugs like ibrutinib. What next? And it's part of that, where do I go with this problem? That depends on funding and all sorts of other circumstances, and what's new on the horizon. So within Flair, if you're MRD negative, we retest the blood, retest the bone marrow. If it's confirmed as being negative on at least 2 consecutive tests, then there's the option, or the stopping rules will apply. If the disease becomes positive again, it becomes detectable again, you start back on the ibrutinib if it's within the envelope of the 6 years. If it's not within the envelope of the 6 years, that doesn't happen. So what do you do? And to counterbalance the uncertainty, I think one has to think of the positivities, the positive aspects of minimal residual disease and what it means. Because when there is no detectable disease, then once it gets down to a very, very low level that you can't see, the dynamics of CLL are such that it may not catch up with you for a very, very long time. So I hear what you're saying, but we've also got to understand what it is about MRD negativity and have some of the confidence that we've learned to have in that as a state, if you like. MRD came up quite a long time ago now as a technique, and I'm sure you're familiar with the concepts of MRD flow and PCR for CLL cells. And one of the early examples of MRD negativity was in CAMPATH-treated patients who had P53 CLL and went into an MRD negative remission. And some of those people are still in remission. This is going back 10 or 15 years. So I personally have patients who I treated with CAMPATH more than 10 years ago who are still haven't been treated again. So I think it's a concept that needs to be tested, otherwise we simply don't know. There is a limited set of resources that we have, and there are side effects that can accrue with the ongoing administration of a drug, whether it's ibrutinib or any other. So if there is a small percentage chance of having a serious bleeding risk, for example, or as we get older, increased risk of stroke, accumulation of heart disease, perhaps requiring dual antiplatelet therapy, or the development of atrial fibrillation requiring one of the direct oral anticoagulant drugs, the DOACs, like apixaban, then those are increased risks. So it's balancing the cost, balancing the risk, and testing the concept of MRD. And that this is something that I think needs to be done. And understanding the impact of getting rid of the disease, because it's something we really need to test. And it's a goal, it's a therapeutic goal. Can we get rid of CLL? And these are the ways to do that, and also the ways to measure the impact of doing that. Otherwise, we will not know. And carrying on with a drug when you have no evidence of disease, but with an accumulated risk of side effects, may not be in anyone's best interest. So I get what you're saying. I think it's, you stop your drug and it's, oh my God, what's going to happen to me? And I think articulating that worry is an important thing to do. Thank you. I don't know.
Ben, one of the questions, written questions, in multi-morbidity situations, does ibrutinib interact badly with NOAC anticoagulants?
Yes. Okay.
Such as, I think,
rivaroxaban. Yeah. So there are a number of what we used to call novel oral anticoagulants. We now call them direct-acting oral anticoagulants, DOACs instead of NOACs. So I hear from my clotting colleagues. Some of which have, or seem to have, more risk than others in terms of cross-reactivity with ibrutinib. Now, whether that's through CYP45A processes, I'm not entirely certain, but drugs like apixaban appear to be somewhat safer. We know that the vitamin K antagonists, such as warfarin, are really contraindicated. And the early studies that came out with ibrutinib were very permissive for antiplatelet drugs, were permissive for warfarin. And we very rapidly realized that there was a significant risk of bleeding. And that seems to work through an antiplatelet mechanism, which is a sort of off-target. So it's not directly the BTK, it's something else that it's getting. It's hitting that. And ibrutinib has got slightly wider effects than some of the newer drugs, the acalabrutinibs, the ono drug, for example. These have fewer off-target effects, so interactions with anticoagulations may be less. Now, there are no strict guidance about what we do with this. I think that there's an accumulating body of evidence and opinion about how we best use these drugs in combination. And I think, like all things in life, it boils down to individual circumstance and risk. So if there's a very high risk of thrombosis, maybe a cardiac stent that needs dual antiplatelet therapy, then you have to think, well, what drug can I use? What can I get access to? Or if there's only ibrutinib, then how do you balance that risk, perhaps combining with low-dose aspirin, for example, or one of the newer drugs at whatever dose is felt to be appropriate. So I know that I've used apixaban at various different doses for my patients with on ibrutinib. Another strategy would be to dose reduce the ibrutinib, but does that make a difference? There's very little evidence that there's a dose-related effect for bruising and bleeding, but maybe there needs to be more data on that. So there's no direct answer, but there's a balance of risks in an individual circumstance. But in principle, yes, you can, and drugs like apixaban may be one of the drugs of choice, for example.
Another question on the question sheet here is FCR still the gold standard treatment?
Yeah, it is at the moment.
And there's a sort of a couple of riders to this. And why do some people relapse quicker than others? And then the third sort of part to it is, what is the average length of remission? So there's FCR gold standard, there's why do some people relapse quicker, and what's the average remission?
Okay. Yeah. So FCR is still the gold standard and has to be pushed off its perch through a process of clinical trials. Whether that's going to be true in all cases, such as the mutated CLL, I think we need to do subset analysis 5 years down the line or whatever. How long remissions will last for depends on whether you complete a full cycle of treatment, depends which treatment you have. So combinations such as chlorambucil obinutuzumab, bendamustine rituximab, FCR, these are all going to be associated with a significant remission in most cases that in the sort of the less toxic type of drugs might be in the region of around 3 years. For FCR is probably going to be a bit longer than that. There is no individual result that you can give treatment to someone and say your remission is going to last this long. When we're looking at median progression-free survival, and those Kaplan-Meier graphs are available to look at, I don't find them helpful. I don't know what it's going to mean for any one person. And you can look at this and say, well, you've got a 50% chance of the disease coming back after whatever it might be, 35 months or something. And say, well, what about me? What's going to happen to me? Well, it could be longer than that. It could be shorter than that. It is literally a toss of the coin, which of those it's going to be. It's just median survival or progression-free survival is just a pivotal moment taken for statistical convenience. So there isn't a duration of remission that you can really say. Don't think that's helpful.
Yeah.
You mentioned the Flair Trial. I'm sure there's quite a few people here who have not heard of the Flair Trial. I have, because I've been on watch and worry for 10 years now. And I think it might be useful for people to know if they look on the Cancer Research UK website. It tells you all about the Flair Trial. I didn't know that until I asked somebody. Can you please summarise what will happen with the Flair Trial in August, September, what are the four, as I call it, NHS lottery drugs? Which four are available? Because I'm unsure of this, and I'm sure other people are as well.
Okay. Well, I mean, we don't usually use ibrutinib frontline, but like idelalisib in the context of 17p deletion, these things are increasingly becoming a therapeutic option. The trial itself is for people who don't have significant p53 problems. Okay, so it's one of the exclusion criteria for the study. So if you've got standard risk CLL and you're generally considered to be fit with normal kidney function within limits, then you may well be offered Flair as a clinical trial. There are other studies available. So for many people, this is not going to be the appropriate treatment. You may be too old. Your kidneys might not work well enough. There might be other circumstances. What you say is really insightful. It's really important, because how often do people get told what is available as a clinical trial? How openly is this discussed? And I know that's highly variable. And we want, we think we put everyone who's eligible for a study into a study, but that's not the case. And, people go into trials when they show interest, when the clinician remembers to do so, right? If the patient asks, you shouldn't even have to ask what's going on there. Sometimes there isn't a trial available at that centre, but Flair is open, will plan to be open in 103 centres around the UK. So it should be widely available as a frontline study. But you must be prepared to go into whatever arm is randomised to. And that means being prepared to go into FCR, because you can't choose. If you go into a randomised study, none of us can choose which arm it's going to go into. So FCR is available, right? So that's standard therapy. You can have FCR on the NHS, or you could make a choice between bendamustine rituximab, chlorambucil, or obinutuzumab, for example, and these choices will be, I think they'll be openly discussed with you about, what would you like, how would you like to have your treatment. In terms of what's, can you get ibrutinib and rituximab? No, you can't. Can you get ibrutinib and venetoclax frontline? No, you can't. And without poor prognostic cytogenetics, you're not really going to access ibrutinib either first line. So FCR or one of the other chemoimmunotherapies becomes your first option. I hope that answers the question. But the openness with which clinical trials are discussed and access to the studies is absolutely paramount. And having the relationship with your hematologist, so you can talk about it openly, I think is one of the first steps. But having to push for something is not desirable. Hi.
Thank you. If you've just recently been diagnosed or watched weight, should you wait until the oncologist says that you might be treated for that? I just said 10 years, it could be a long, long time. Or should you have the tests to do your prognostic markers straight away so you know bad or good news?
Yes and no. I think it's worthwhile if there's access to one of these observational studies where you can take samples for biobanking. I think that is very useful. There isn't anything that I could do taking your cells and analysing them that's going to bring forward anyone's therapy. So doing the tests immediately might give you some information that you can work with, and some people will find that very helpful. So if it's available, then you can discuss that with your hematologist. Now, it may not be available outside a specific teaching centre, for example. So if you're at a university centre that has an interest in CLL and they want to take it for their own nefarious purposes and experiment on those CLL cells in some dark room up the road in the university, then you're going to be asked, can we have some of your cells, please? And out of that, okay, with full informed consent, but out of that will fall some of those prognostic markers, such as p53 mutational analysis, or sometimes the FISH. But the FISH test is an NHS test, and we would do that, and I would certainly advocate doing that before treatment, so that we make the correct treatment choices. So in the real world, you test before you need treatment, and there's because of things like clonal evolution, it's not really going to tell you very much, perhaps for those for quite a long time.
Nothing changes. Does anything change in that?
Yeah,
like if you
yeah, it might do.
Well and healthy, and you still lost weight, but obviously you've got CLL.
Yeah.
But then you became quite ill, and it became worse. Does anything change? Is it daft to have genetically two tests almost, because things can change?
Yeah. I think that's the value of an observational study such as being set up, so that we can analyse what does change and what is the evolutionary process in CLL generally. For any one person, there may be clonal changes that occur, so it's not going to alter any of your management or treatment, and there's no advantage to seeking to get it done, if you like. There are always going to be individuals who need data to help them understand what's going on, but it's not going to change anything. So there's no need. There's really no need. If things change, lymph glands get bigger, blood counts change, all the usual treatment triggers, they haven't altered. So treatment triggers in CLL, we didn't talk about, this is the basics, right? That's not what I'm here for today. But the basics, treatment triggers, hemoglobin. Is your hemoglobin okay? Is it falling? Does it fall below a threshold? Is your platelet count okay? Is it falling? Is it going down below a threshold? What's the white cell count doing? What's the lymphocyte count doing? What's your lymphocyte doubling time? Okay. How rapidly is it going up? I don't mind if it's 50 or 100 or 200, as long as it's steady. It doesn't matter what it is, what the number is. The number doesn't change my view of how stable someone's CLL might be. Are the lymph glands more or less stable? And are you well in yourself? Is the spleen getting bigger? So those things are typical treatment triggers, and they can take a long time to change. So learning to live with this uncertainty and this process of watching and worrying is a real difficulty with CLL.
Just one more written question here. Did I understand it right that starting ibrutinib can increase the risk of Richter's transformation?
Yeah. I'm not sure that's strictly correct. Okay, yeah. I think that when you get to needing second, third, fourth line drugs, particularly in recent years gone by, when we were all clamoring for some answer to an unmet need, then many of those patients, perhaps included in some of the early clinical trials, would have been just on the borderline and developing Richter's anyway. Quite possibly. Okay? We don't really know that. But I think we're seeing increasingly a cohort of people who are receiving ibrutinib and similar drugs at an earlier stage.
There's a rider to this one, it may have to be a relatively brief response. Any advances in treating Richter's transformation?
Yeah, so I think it's the Stellar trial of R-CHOP with or without ACP-196, acalabrutinib, is a trial for Richter's transformation that will be opening across the UK at selected sites at least during the course of this year. So adding a BTK inhibitor to chemotherapy may improve outcomes for people with Richter's transformation, but it remains a very, very difficult problem.
Ben, thank you very much. I feel as if we've covered a a huge amount of ground. Oh, I'm sorry, there's one, can we say, perhaps just one last question, beg your pardon, yes, sorry about that.
Yeah,
That's no problem.
Thanks for testing my fatigue-ridden brain with an excellent presentation. My question is, are the threshold triggers the same in refractory CLL as they are in the first instance?
They are. And I think this creates a level playing field in terms of responses for clinical trials. Otherwise, you're comparing apples and pears. So, yes.
Thanks.
Well, thank you very much, Ben. That's been absolutely fascinating. And I mean, I found myself thinking this is an absolutely terrifically interesting area, and then forgetting I've got CLL.
I said right at the beginning, yes, it is interesting. Yes, it is fascinating. But we mustn't lose sight of this human problem.
Yes, exactly right. But I think you've done a terrific job. But thank you very much, Ben.